Welcome everybody. We're obviously gathered together from all parts of the world to contribute to this the MOOC that we've been organising to the University of Edinburgh, Brain Health Scotland, and of course now Alzheimer's Disease International. So thank you for making the time and effort to contribute to this. My name's Craig Ritchie. I'm the Professor of Psychiatry of Ageing at the University of Edinburgh and Director of Brain Health Scotland. And I think before we start, it'd be nice just to go around the room, go around the world and introduce ourselves. So on my screen, I've got Amalia, then Ishtar, then Rochelle, then Wendy. So why don't we go in that order? So Amalia.
Hi, everyone. I am Amalia Fonk-Utomo. You can call me Amalia. I'm from Indonesia. I am Deputy Executive Director of Alzheimer Indonesia. And I'm also Alzheimer chapter managers in the Netherlands because I am based now in the Netherlands. In a way, COVID brings us, we can work from everywhere. So I'm working for Indonesia from the Netherlands also. That's it. Thank you.
Thank you. Ishtar?
Hi everyone, my name is Ishtar Govia. I am a senior lecturer in epidemiology at the Caribbean Institute for Health Research, and I'm also the Jamaica project lead for STRIDE.
And hi, and Rochelle?
Hi everyone, I'm Rochelle Amour. I'm also on the STRIDE Dementia project in Jamaica, and we are based at the Caribbean Institute for Health Research at the University of the West Indies, Mona.
And finally, Wendy.
Well, hi everybody. I'm Wendy Weidner. I'm the research and policy project lead at Alzheimer's Disease International. I too am on the STRIDE project, which actually, and just in case you don't know, stands for Strengthening Responses to Dementia in Developing Countries.
Excellent. Okay, well, thank you, everyone. I think, obviously through the work of Alzheimer's Disease International and through the STRIDE project, etc., we all recognise that Alzheimer's disease and dementia isn't a local issue in one or two countries. This is truly a global issue, and we considered it so important from within this, this MOOC that we've been running to bring in that global perspective on some key issues. And we wanted to cover, I think, three particular topics. I mean, number one was, we talk a lot about, and sometimes even within the same sentence, we say dementia prevention and brain health. I think we wanted to see how those terminologies, those phrases are used in different settings, and that was one topic we wanted to explore. And in that, I think there's a huge move, and ADI have been really pivotal in making this happen at a global level around prevention. And prevention requires early detection of disease, whether it be for public health or for clinical work. Talk about some of the initiatives and some of the aspects of early detection in our different regions, different countries. But also, I think, finally, we want to talk a little bit about global collaboration. What can we learn from each other? This isn't a matter of, research taking place in one country or one location to be imported or exported into another. This is about working together, I think, collaboratively. We can talk about maybe some of the strengths and the opportunities, but also maybe the challenges with that. So, I don't know. I'll just let things flow as naturally as possible. But maybe we could talk a little bit about this whole issue about rebranding. I mean, maybe let's start in Jamaica. Brain health, is that a term that has resonance in the Jamaican community?
Not quite yet, and I will let Ishtar jump in as needed, but I definitely think that in Jamaica and in the wider English-speaking Caribbean at least, we are still working towards establishing mental health as a priority. And so the introduction of the idea of brain health has really taken hold in higher income countries, and I know it's been a phrase that has been around for quite a few years, for example in Europe. But for us on this side of things, it's something that I definitely think is still clouded in a bit of mystery and associated with, biomedical researchers or, hospitals, very fancy institutions. It's not something that it's made its way into mainstream discussions and conversations, or even policy level conversations. And so while it is definitely a great way to reframe and change our approach to these issues by really speaking to that very human element of health and wellness, and the fact that we all have brains and we all need to take care of our bodies and our brains. It's a very, very simple human way of framing mental health and mental disorders. But unfortunately, there is still that element of, well, that sounds like neuroscience. That sounds like something that the doctors need to be concerned about, and we are general medical issues. So there definitely, as we always say, needs to be a lot of collaboration, conversation, and education, especially around what this represents and how we can translate that in a way that people can see the value in it and apply it as needed.
So Ishtar,
yeah, I think Rochelle hit the nail on the head there with talking about how brain health has a very biomedical association. So when we do our talks with community members, with places of worship, with other non-governmental organizations, even when we have our meetings with ministers, it's very challenging to get them to think about brain health as a life course issue, as something that really needs to be addressed at all stages, from in utero to in later life, and even in the stage of later life, even when we're thinking about palliative care. For a lot of folks in Caribbean countries, and I would imagine in many lower middle income countries or resource constrained contexts, thinking about their brain as part of the entirety of who they are is not something that they get a lot of socialization around. Okay. So connecting, for example, what we say a lot when we do talks is, your brain controls so much of who you are and how you move, how you speak, that you can see, that you can hear, all parts of your body. So when you have a stroke, for example, it's not surprising that some people may lose the ability to speak, or some people may lose the ability to operate certain sides of their body or certain parts of their body. And so that tends to be a big moment of aha when we're doing our talks.
It's really, before we come on to Amalia and Wendy, I'm just absolutely fascinated by your answer, because one of the reasons we actually introduced the term brain health, and we prefer it, was actually to get away from the biomedical in Scotland and the UK, because we consider that dementia was the clinical term. We wanted to try and get away from that more health orientated thing. So already fascinating discussion about the accessibility of that term and the perception of that term in different communities. So Amalia, from an Indonesian stroke Netherlands Dutch perspective.
Yes, yeah, pretty much it's actually almost the same like in Jamaica, because from the low middle income countries perspective, brain health, it's still really far away from our thoughts. Okay. So we're still, especially now during the pandemic, mental health, it's becoming more popular, but still not related to brain health at all, and also to the biomedical also. And I think Indonesia we are really big countries with a lot of islands. So the terms of brain health is already making more stigma to everything from dementia and mental health and brain health. At the end, if you explain that this everything, like Ishtar said, is everything is commando is from the brain. Everything is ordered from the brain, but it's really so far away, really so far away. So So up until now, we're still using the terms mental health and as an opening. Even we use memory loss and then mental health, and then it's for the brain. Yeah. So it's really the stepping. It's really a lot from the dementia, Alzheimer, mental health, and the brain.
Yeah. So Wendy, from an ADI perspective, I guess you are by definition working across numerous communities and countries, and even within countries there's going to be different perspectives. So I mean, does this conversation surprise you? It's certainly something I hadn't thought about before, to be honest.
I mean, I think I was surprised by the biomedical association as well, because I sort of thought, you know, in a way, the sort of sentence of, you know, looking after your brain health seems sort of intuitive, you know, that you know, we have our like sort of supercomputer that's controlling everything, and it's an organ just like our heart and our kidneys and everything, and we need to take care of it. But it is a shift, it's a change, isn't it? And I think, you know, I think anything around mental health, anything around dementia, anything around our brains right now is sort of a mystery, and that mysteries can kind of be a frightening, scary thing if we don't understand them, and so that can bring along with it stigma. And we know from the World Alzheimer report that we did in 2019, there's still a lot of stigma and a lot of misunderstanding about dementia itself. That you know 2 out of 3 people still think that it's a normal part of aging. So we need to sort of educate. And I think, Rochelle, it was either it was you that talked about collaboration and education, and I think that's and Ishtar, you mentioned the life course. That's what really makes me interested about brain health, is that whole life course idea, and starting young and educating people young, and maybe breaking that cycle of stigma at an earlier age. You know.
Yeah, and I think one of the again, coming back to our experience or our thinking, and you know, we're early in the course of this as well with Brain Health Scotland, is that brain health terminology, the brain health phrase, is accessible across the life course. You know, children have brain health issues, they've got, you know, things they can do to maintain brain health, teenagers, midlife, what have you. So it doesn't necessarily tether it to a dementia story. It makes it, you know, again, like you said, Wendy, across the life course. But I do think that the you know, the other thing that we really wanted to talk about is if we are going to think about prevention, then we've obviously all read the Lancet Commission report that talks about risk factors, about how they maybe impact on your risk of dementia in midlife or even earlier. So there is a kind of I'd be interested to hear your experiences of how you start communicating public health messages, and also maybe individual assessments and management plans for people before they get dementia, early detection. You know, how do you get there to prevent dementia? Maybe, I mean, Amalia, maybe start with you this time. I mean, what's the kind of the view in Indonesia about prevention and early identification?
Yes, maybe I can share the best practice from Indonesia, how we entered the to communicate this, because as we know that it's still a big stigma in Indonesia for starting from the background of the Alzheimer. And then we have the terms from the memory loss, because if we are moving to the memory loss, like, oh, I forgot. Oh, yeah. Is it normal, or is it that not normal? People still don't know about it. Oh, that's normal. And then that's beginning that people accept or, you know, ignore that you forgot something, that it's normal, that actually it's not normal. So with that window, we try to come in from that window, that because do not underestimate memory loss, whatever it is, just try to find it. So from that terms, we are moving. So if you are having that symptoms, then you might can get dementia symptoms, something like that. I have here actually, this is the, I'm first started with the English one. We have this small brochures, identify 10 signs warning of dementia. Is it in English? And then it's really, really small. So it's really like a pocket handy, so it's not intimidating. So if people think that, no, I don't forget anything, but just, you know, bring it, put it in your pocket. You can read it at home, something like that. And then from there, actually, people are coming back to us, and when they read at home, oh yeah, actually 5 of this is me, or 7 of this is me. Is it normal? And then they said, it's okay. Yeah, there is some normal and there is not normal, but people start to recognize, oh yeah, this is that one. This is a signs of dementia. Is it normal or not? And coming from this also, this is in English, and then of course we have first actually it's in Bahasa Indonesia. This is Bahasa Indonesia, and then we even have it in Dutch. So it's pretty simple that everyone is actually can adapt. And Indonesia have we have 700 languages.
Wow.
Yes, because we are island countries. So imagine if a countries with an island, it's separated and it's really, really what you call remote. Yeah, people really speak a different language, but we have one language, Bahasa Indonesia. But still, it's more approachable when we speak the language. That's why we try to adapt these small brochures to them, with all the language, not 700 yet, but it's coming from Bahasa Indonesia. So from that perspective of memory loss, and then, that's something with your brain, and then dementia and Alzheimer and things is related to the brain. And then they are getting more know about, okay, it is for my brain. My brain is just another organ, need to be practiced. And a brain gym also, we told them to do the small brain gym like you do with your other parts of your body to also do it for your brain.
And I think that the whole language aspect is, we have to try and communicate. Of course, that's what we're doing with our, patients, our public. And consistency of messaging and making links between, as you said, Ishtar, about a stroke and a weakness and these sorts of things. We need a consistent and credible message. And I wonder to what extent, even things like, we did a survey here in Scotland. We recognized that a lot of the people weren't making those links between things like nutrition and exercise and brain health. Do you think that's the experience here, that there's things that are risk factors that you can actually maybe, does smoking cause brain health? I can't remember the number now, 25% of people in Scotland didn't make a link between smoking and brain health, which seems to me, really surprising. We shouldn't be surprised by these things. Ishtar, in Jamaica, is it easy to communicate those links? Do people understand the links?
It's a multi-stage type of approach that we realize that we have to take, because we can't just jump in and start to talk about those links. We have to first sensitize persons that dementia exists, that there are more than 100 different types of dementia, and here are some things that you need to be aware of in thinking about all of these different types of dementia. Rochelle, I'm sure, is going to jump in shortly and talk about the multi-pronged strategy in terms of the different audiences we have and the different ways in which she's really tackled knowledge translation, knowledge exchange work with those target audiences. But what we've realized is that our discussions with places of worship, with non-governmental organizations, with even stakeholders from ministries, as I've mentioned before, that all of them, even when we do radio programs, that all of them start with this curiosity. What is dementia? How does this connect with my brain? Does this connect with my brain, or is this really just about old age? Is this typical? Should I be expecting this? How do I know this is not the same as, a normal sign of memory loss for somebody who is my age? So it's really interlinked with stigma. But I think your point earlier, Craig, about the public health messaging is really crucial, because when we attempted to talk to the Minister of Health and Wellness about this, for example, and he kept referring to dementia as a mental health condition, and I would say, well, it's actually cognitive and it's neurological. He said, see all of that, that's too fancy. That's too fancy. When we're talking to people, it's hard enough for us to get them to understand mental health as an issue. So you telling me now that cognitive health is different from mental health is different from brain health, that's not really how we're going to have to be messaging here. So I think that was an important reminder to us in terms of how we talk about communicating a message, how we talk about prevention, how we talk about what prevention entails, and the different types of prevention strategies that are appropriate for different types of dementia. So we may have this information. That's our role as the people who are trained and exposed and oriented in this area. But how do we communicate to somebody, here's what to look out for with Lewy body's dementia, here's what to look out for with vascular dementia, here's what to look out for with Alzheimer's dementia, without overwhelming them? And that's where somebody like Rochelle comes in, because she has really specialized skills in terms of this knowledge exchange work.
So I think before we bring in Rochelle, just very, very quickly, and this is one of, I think, a key issue, and one I don't know if there's a real answer to, but it's worth discussing, is that, okay, I'm a psychiatrist, you know, I deal with mental health, but I know that this is a brain disease, that symptoms may look like symptoms you get in mental health conditions like depression, anxiety, such like, but I also know that a lot of patients don't feel they're mentally ill. They have a brain disease, so they don't necessarily want to have that, dare I say, stigma of seeing dementia as a mental health condition, but would rather see it as a neurological condition or a brain health condition. And I do wonder sometimes that, you know, the way that things have developed in the UK and Australia and other parts of the world, with dementia being the remit of the psychiatrist, is something which we could back up on and maybe start again. And if you're beginning these conversations in new communities, should you start from a mental health perspective or should you start from a brain health perspective? It's just Rochelle.
Can I just jump into that one, Craig? Yeah, I think it depends on your audience again, because with the policymakers, you have to figure out your point of entry. And sometimes, because there is no dementia-specific policy, you have to piggyback on a mental health policy or a non-communicable disease policy. If your target audience is really alerting people who may be at risk, at high risk, then, you know, your general practitioner, your family doctor, the point of entry, where are people actually entering into the healthcare pathway? Or it could be also, where are people entering into the social care pathway? Because, and that's an area of vast underdevelopment in so many countries, because it's seen in such a medicalized way. But if we were able to start to make people aware of here how you're all affected when somebody within our network is living with dementia, when somebody within our network is living with a neurological condition, then it may be easier to start to have those types of conversations.
And I know, Rochelle, you're desperate to get in, and it's interesting, the Brain Health Scotland, it's with the Scottish Government, and we deal with public health, and we're finding new conversations, and I think this hasn't been fixed. I think there's a really interesting series of conversations to have over the months and years ahead. But Rochelle, this issue about prevention and early identification and mental health, brain health, what's your perspectives on this?
I think that Ishtar really, you know, had a strong point there about it really just depends. And I think that's the whole point of this conversation, this global conversation that we're having right now. Because when you're in a context where people have known about dementia and you've had a public health policy around dementia for several years, and then you, as a psychiatrist, have a client who's been sensitized to these things, he has that choice. There's that option of preferring and understanding that I would like to tackle this as more of a neurodegenerative issue, because, you know, I'd rather not, you know, have it associated with dementia or mental health, because that knowledge, that baseline knowledge, it exists and it's there. So when it comes to messaging and prevention, I think it's going to be very interesting to see how this pandemic plays out in terms of awareness and initiatives that come forward. And I think that is going to help direct our work, because, you know, as was said earlier, the idea of mental health is definitely at the forefront, and it's a really interesting opportunity for us now to see how people are responding, and to see now that there is a lot more awareness, not just for people who are maybe dealing with this for the first time, but also for the people who are dealing with them, living with them. You know, it's a life course issue, not just because we can have these experiences at any age, but because we are a community. We take care of each other. They are caregivers, right? And so it's important, but I'm very curious to see how the people really lead this conversation, and then it's up to us to respond. As the people with the data, doing the research and the information, you know, it's not just our responsibility to disseminate that information. It's our responsibility to adapt that information and be aware of the context in which we're providing this information. So definitely targeting different audiences and tailoring our messages is important. But then in everyday communication, you know, in things, you know, in everyday marketing and just being human, there are messages that cut across, you know, very different boundaries and very different segments, just because they are simple and they're valuable to everyone. And I think the value of mental health issues is increasing, and that means the value of this brain health opportunity is increasing. And it's really our responsibility and our opportunity to take and kind of move with this. And it's never going to be a cut and clear answer. It's definitely going to need a lot of thinking and adaptation.
I like that. We got to move with it. Yeah, exactly. I mean, I think we can't say there's an answer here. We have to, you know, pitch that answer. And we're right, you're wrong. You know, this isn't how it works. And you also picked up what you said there about, you know, listening to people. And I know that obviously ADI did this huge global online survey, Wendy, which I'm not going to ask you to summarize because there was so much in it. But those are the opportunities, aren't they, to let the voice of people either living with dementia or people at risk of dementia be heard. So, I mean, presumably ADI learned a lot from that survey last year. Was it a year ago now, or more recently?
Last year.
Last year, yeah.
And it was a phenomenal response, really. And we did learn a lot, because we realized that people knew a lot less than we thought that they did. And also that we were really surprised that I think it was something like 62% of healthcare professionals thought that, you know, dementia was a normal part of aging. So we realized, in terms of a baseline, we have a long way to go. But I think this is a really interesting conversation, because one of the key things about messaging is about reducing risk. It's not about only telling people, informing people about dementia, but also giving them some hope. And that's why I like the idea of this brain health initiative, because it empowers people to do something earlier on, and, you know, to reduce their risk. It gives, you know, in the absence of a sort of disease modifying drug right now, it enables people to sort of take steps to do something and take back some of that control, change some of the, you know, you can't change your genes necessarily, but you can change how you live so that you can give yourself the best chance to have a healthy brain. So that's
and in terms of that, you mentioned, you know, the hope and even in the absence of a drug therapy, I think a lot of us, you know, again, referring back to the Lancet Commission report, maybe Mia Kivipelto's work on the finger study, etc., there are things that are actionable that can make a difference to the process, to the chance of developing dementia. But I think in terms of, you know, the the global nature of this disease, I must admit I sometimes worry that a lot of the research which is taking place only seems to have an output which would apply to a very small fragment of global society, because it relies on, you know, expensive medicines or expensive imaging or expensive blood testing. And even within high-income countries, there's huge socioeconomic disparity and access to these things. And I wonder how, as a collaboration globally, we can ensure that the research gets done in the right way, that people can all benefit globally. I mean, I know we talk about these things a lot, but how do we make the research we're doing in terms of early detection and therapies and public health interventions truly global? Amalia?
Yes, interesting questions. How to make it more global? Well, I'm coming from
global. Yes.
Yeah.
That's like a bit tautological.
Now, interesting is I'm coming from my background is advertising. Yeah, great. So, so I always interested in messaging. What we are now talking is what we have to say. What we have to say, is it like brain health, mental health, and to who? To the private sectors, to the government, to the mosque, to the church, to the, yeah. But again, the gap between the scientific, all these messages, and to the people who doesn't really understand, and I am like me in the middle. I always challenging. That's why we are coming like this one, this jangan, oh okay, this one. Yeah, this is the do not underestimate memory loss campaign. This is in Bahasa Indonesia, but it's translate do not underestimate memory loss. It's already more than 7 years we are rolling it. As a advertising and marketing and a creative person, it's like, I want to do other things. I want to do other things. It's just like every time we are doing the same message. But it's not enough yet for Indonesia, because we are big countries and with all the language. It's not going global yet, or just, you know, even we reach Indonesia, we're not reach Indonesia yet. So I always challenge, like, can you make the message more friendlier? Because the gap between all the result and the researchers and the message we want to address to the people, it sometimes is just too scientific. It's too, and then bring it them, so make them, this is really, no, it's not friendly, but it's friendly message. It's not a friendly message, but bring it them to a friendly, what you call, way to bring it to them. And I see a lot of a more emotional attachment. And now you can see actually in the global perspective, we can adapt everything, because emotionals is actually like music, colorings, paintings, what else? Singing, yeah, it's general. We can use really general things to make a global. And there is songs also globally known too. So it's the emotionals, especially during this online, it's really connected. We make I will show you a bit. We made like coloring sessions. This one, you know, this is my background is terrible moment. I really have to what happened, yeah. So maybe I just not using the now. Okay, yeah. So like this. We are using this coloring. We send it through online everywhere to Indonesian across the world, and they are printing it. And then we do a sessions with online and put a music, put Indonesian music in the background. Some like lights Indonesian music. So everywhere they are enjoying it, and people are sending it, post it in social media, or even share it in the WhatsApp group, yeah, with all the different, yeah. This is, let's talk about dementia. It's already, you look, yeah. So, and it brings, it's universal language. It is really universal. Let's talk about dementia and or brain health. So you can deliver the message in the pictures, in the songs, in colors. It's general. So
think,
so it's yeah.
No, you go, please finish.
Yeah, so it is one of, and mixing it with the colors and pictures and the songs in between and doing it together through online as a meaningful engagement, doing it together. It's risk reductions already, making you happy, making your brain also working, picking the colors. And so we doing it like Indonesian, but without we know it, it's globally, because Indonesian across the world is doing it. So when this is universal, then we can do it for everybody too.
And
That's it.
That final, it's universal, we can do it for everybody, is something, again, coming back to the research, the drug development, the early detection techniques. Are they universal, and can they be used for everybody? And I wonder how we probably identify. I think it's fair to say that it's not. you know, lumbar punctures, PET scanning, monoclonal antibodies. These are things which are going to be super expensive and super hard to access. So how do we make sure, in a sense, as a global community, that we don't go down, to use maybe an English term, to go down a rabbit hole and end up in a place we don't want to be, and we can't pull ourselves out again? I mean, from a Caribbean, from a Jamaican perspective, when you look at these things happening in America and in Europe and Australia, what's your reaction to it? Do you think, oh, great, but that's nice?
Yeah, there's definitely some of that.
Yeah.
Because it's all wonderful to hear about these specialized testing techniques or these specialized diagnostics that require expensive pieces of machinery, etc. But most of our hospitals, that people who are from lesser resource community context are having to access, the public healthcare system doesn't necessarily have great numbers of the very basic types of machines and lab testing equipment, etc., that are necessary for other things, let alone for something more specialized. So it becomes more prohibitive. It becomes more accessible only to a particular segment of your population. And in that way, it perpetuates and increases, intensifies inequities. It intensifies inequities in being diagnosed, and then clearly intensifies inequities in being treated. So one of the major pushes that we've been really very encouraged to hear more people talking about, even in the ADI webinar that happened recently on risk reduction, is to hear more people talking about population-based interventions, policy-based interventions, really trying to adapt, for example, NCD best buys, and figuring out how those that are population-based, that are policy-related based, that those can be implemented. And the question that you'd started off with, Craig, about, how can it be more global? I think it was like a Freudian slip, because it really did communicate in a way that it's not very global. That there is this branding of things as global health and global health related research and funding for global projects. But really, we know who benefits from these things. It is people who are positioned in high income country contexts, researchers who are positioned in high income country contexts. And when we try to get in through the door, as investigators, as non-governmental organizations, we try to be able to access some of these opportunities. The door is closed often unless or until we have a partner from a high-income country context, if the opportunities are even open to us in the first place to be a co-applicant or a lead applicant. And so there are inequities across the spectrum. There are inequities in terms of how our communities are set up. There are inequities in terms of social care services are set up. There are inequities in terms of which country governments have a louder voice around the table at large meetings like the World Health Assembly or United Nations, etc. And there are inequities in who gets funding and how the funding agenda and prioritization is decided and then allocated. And those are all inequities that we need to have our eyes wide open about. And then we need to be very, very ferociously, very fervently determined to do advocacy around.
And I think the there's no easy solution to this. And I think all the things you've articulated are, you actually sometimes, sitting here in Edinburgh, feel quite painful about, because you know that when you come to work and you do the work you do, your horizon maybe isn't as wide as it should be, and you are thinking about what's immediately in front of you with your own research, with your own activities. But one thing I will say, and Wendy will agree with this, part of there's a new initiative, the Davos Alzheimer's Collaborative, which is initiating next year. And I do know from my involvement within that equity of access is within the DNA of the whole project. It's not an afterthought. It's not a nice to have. It's an absolute need to have. An ADI or a key partner in that. So I'm not saying that'll solve everything. It probably won't, but at least it's probably a step in the right direction. Rochelle, globalization.
Yeah, I think that everything that Ishtar says, there's so much resonance, and I mean we can talk about that all day, about what these things really mean for us. But going back to our conversation earlier about the messaging, the reason that we were able to have access to such different segments and have the opportunity to have that experience about our messaging is because Ishtar, Jamaica being quite a small place, but Ishtar is very well positioned to build trust and worked very hard to build that trust. And it's really important for us to not just build trust within our research communities, but between our research communities and people. And we know that there has been a real shift in last years, even when it comes to funding, like what you just mentioned, for this need for impact and equity. And that is very, very important, because it moves us along the pathway of not just giving that lip service or service in the way things are designed or set up, but service in the way that we now have to get our hands dirty. There is no way that the science can exist separate and apart from the people it's meant to serve. And there is no way that the work that we do, and it's very unfortunate, Craig, that you have that struggle with the work that you do. Sometimes maybe it's not having a wide reach, but part of bridging that gap and getting that reach is really going out there and meeting people where they are and building that trust. And we can't deny that in the context of inequity, especially in 2020, the issue of mistrust, especially when it comes to anything associated with medicine and doctors and research, even in today's conversations around research and vulnerable groups and where things are trialed and how they're trialed and those ethical concerns, they still persist today. And so when we are trying to support and make a difference and have an impact, we have no choice but to be very frank and to be very like it's just said, going with our eyes wide open about these realities and be willing to have those conversations and be willing to have a conversation like this, which I think is great. So, we do have a lot of work to do as a community, and those of us who are kind of on the outskirts involved in knowledge exchange work or NGO work, we also have, a responsibility to help researchers and help the medical professionals to meet the people and bridge that gap, not just through communication and policy, which, is also, there are so many other layers to that as well. It's not simple, it's political. Policy is political and it has to be, right? But in terms of making sure that we have this global messaging, it's remembering that there are so many different levels to our global community that we need to move from up here down all the way down here. And it's going to take a lot of time. and a lot of work and a lot of very uncomfortable and unpleasant realities and conversations, but it can happen and it has to happen, especially in 2020. With so much tragedy and change comes this opportunity to really rebrand and refocus and have new approaches and tackle things in new ways. And I think all of these conversations are a big part of that change.
And I think from what you're saying, there are uncomfortable conversations to be had, and there's difficult conversations to be had. And I think what we're talking about in terms of global collaboration is a series of partnerships. And like any other partnership, a successful partnership is based on trust, honesty, and mutual respect. And I think that's maybe what we need to start off with, is the principles in that relationship. Then we can have those uncomfortable conversations. They don't hurt because they're honest, they're trusting, and they're respectful. So I think we're 2020. Okay, let's watershed moment. Let's have those conversations in that context.
Can I add something, Craig? Yeah. It's just and it's before you said the partnership, I just remember, because you said global again. We are Indonesia. We are now having a training program with the Netherlands, so that's why my role is a bit also in between. So I think for going global, it can be start from the regional too. It's not like going global. From Indonesian experiences, now we have a 3 years program, a training program under the ADI also with the Netherlands. Of course, it starts good because the connections between the Netherlands and Indonesia is really bond. Yeah, it's really thick because of the colonial and the past. So the connection is really good. And then before that, actually, we have already twinning program. And now the twinning program is done, the first part, and then we are continuing for the next 3 years. So we have like 6 years twinning program, Indonesia and the Netherlands. And from there, Indonesian people, we are exchanging best practice. And we are adapting each other, actually. So it's not just the Netherlands sending the practices to Indonesia because we are low middle income countries. But the Netherlands also adapt something from us, like home care, more into the communal and also the immigrant. So starting from the twinning program, if the countries across the world can look for the connections, I think it's nice too. And now and apart from that, also we have working regionally with Asia Pacific. So I think by step, from our experience, learning like our twinning programs, and it's also based on trust. It's really based on trust. Even our what you call founders, yeah, and all our directors in Indonesia, they are surprised that how the Netherlands and Indonesia can really smooth doing all. Of course, there is uncomfortable conversations too, but we are really smooth doing everything because the trust is there. And now it's extended, so the trust is there, and then we are comfortable, and they're extending. So it's adding on to the to how we can go global and the trust partnerships.
Start with local, regional partnerships, and then we'll expand that trusting environment. And I think to one point, again, I don't want to overdo the analogy about partnership, but the best partnerships are those where you listen more than you talk. And I think what you were saying there about, picking up things in the Netherlands that have been, best practice in Indonesia is about listening to what's happening all over the world. So, Wendy, I want to pass to you. This has been a fantastic discussion. And I think we've all said we could have probably spent many more hours in these, and I'm sure we will, conversations. But just some reflective closing thoughts about the issues that we've talked about today from your own personal as well as from an ADI perspective.
It's been such an interesting conversation. And as we've been talking, I've been jotting down words because I've been thinking a lot about everything you're saying. Because I think for me, this is all a real journey that we're on, and I think that, it's you were mentioning we've got to listen more than talking. And I was always told as a young child that, God gave us 2 ears and 1 mouth because we're supposed to listen more than we're supposed to be talking, it was my mother. But I think that is absolutely right. And in a strange way, we keep coming back to 2020 being such a complicated year, but it's almost, in a way, created this strange opportunity for us to have these conversations in a completely new way. Who would have thought that we would be having this conversation so easily in this MOOC, you know, sitting in Jamaica, you know, the Netherlands, and in Kent and in Scotland, you know, and we're having many more of these. It's opened up a window. Despite the fact that we're in a really divided time, we are connecting quite a bit, and I think we need to keep listening. And for us at ADI, certainly this year has created an opportunity for us to talk about some really important issues, because COVID has drawn us together around what's happening to the people that are living with dementia right now, and thinking about possible solutions, you know. And one of those is talking about brain health, you know, talking about how we can be a little bit more proactive, and how we can think about how we reduce our risk, and at the same time continue those conversations about what are our entry points with different groups, you know, different stakeholders, whatever they are, you know, to educate people along the way. So, you know, to talk a little bit, to listen more. But I think the thing that's really come out so much is the idea of trust and equity, and that we have to continue those connections and working together. And it can't be top down. We got to meet in the middle, which again has a lot to do with that listening and creating opportunities. And I'm hoping that we'll be able to have more conversations like this, because you've created a great platform for us to start having these conversations.
Well, I think it's only for me to just say a huge thank you to all Ishtar, Rochelle, and Wendy for this, you know, session we've done for the MOOC. But as you say, Wendy, this is not the end of the conversation. I think this is just the beginning of it. And I hope that from what people have spoken about, from the people who are signing up to the MOOC, they get a lot of food for thought. You know, there's a lot of challenging things that were brought up. There's a lot of issues that people will go away and think about. And that's how it should be. We didn't probably provide a huge number of answers here. What we did was outline maybe some of the issues and some of the problems which we need to be able to address in the future. So Amalia, Ishtar, Rochelle, Wendy, thank you so much for your time and effort this afternoon, this evening. Really appreciate it, and we look forward to catching up again really soon. Thank you.